Great. Good afternoon, everyone, and welcome to our third week of our October webinar series. I'm very excited today to have three amazing speakers, and we just had a few technical difficulties, so we're going to leave this slide presentation up, and I'm just going to speak to our land acknowledgement to welcome everybody. And please do also take a look at our archived content from the week past and the week before that, exposures of concern, and the silica control tool launch, and what the occupational illness prevention, occupational health and safety system are doing to prevent OC disease. And this is a big part of that. We're kind of continuing the thread today. And so we are participating from various locations, all of us, and I want to acknowledge I'm connecting from Mississippi Mills, which is located on the unceded lands of the Algonquin people. Last week, we focused on the land and the 7 gifts with the animals representing various of the gifts. And today I'd like to focus, and I stole this from a colleague who shared it with me, and I loved it. It was one of the best land acknowledgements we had, and Lynn and Janet have heard it before as well, but specific to my river. So last week, today I'd like to focus on the Mississippi River that runs through Mississippi Mills, which was an important canoe route where people traveled to seasonal harvesting areas for wild rice, berries, game, and portaged by the falls and fished. Although the Crown had guaranteed 1763 that these lands would remain in the possession of the Algonquins, the British government in 1783 chose to ignore this promise and encouraged settlement here by loyalists fleeing the United States. As a person who calls Mississippi Mills home, I have the privilege of connecting to the land through the Mississippi River my entire life, and I really appreciate paddling on it, and I feel that it's the thread that connects all our efforts symbolically around occupational disease prevention in today's presentations. So to end this land acknowledgement, I welcome and encourage you to explore a local waterway and reflect on its history of connecting people, our collaborations, our connections, what we need to do to make this happen across places throughout time. In doing this type of reflection, I have a better appreciation for how the rivers we see and hear and the small parts we may access daily are part of a larger system and purpose. I'll pause to give everyone a moment to think of a river. Can you picture where it ends, where it starts? How and by who was that river used to enrich lives? And thank you everyone for joining me in a reflection and the land acknowledgement for today's presentations. So without further ado, we have Dr. Lin Holness, an occupational medicine physician and professor emerita at the Dalla Lana School of Public Health and Department of Medicine at the University of Toronto. She's a staff physician in the Division of Occupational Medicine in the Department of Medicine at St. Michael's Hospital and a scientist in the MAP Center for Urban Health Solutions. She's the director of the Center for Research Expertise in Occupational Disease. Her research interests in occupational health are very broad. Her main research focuses on prevention, healthcare utilization, diagnosis, return to work, and outcomes through the lens of occupational skin disease. Joining her is Janet Brown, supports the strategic research efforts at the MAP Center for Urban Health Solutions at St. Mike's Hospital. MAP's research tackles complex community health issues, many at the intersection of health and equity. Janet's worked with Dr. Holness for several decades and brings a deep experience to both the health and safety and the healthcare systems. Welcome to both.
Thanks, Kimberly. So Janet, I think you're going to start.
I'm going to start in. Hello to everybody. Sorry I can't see faces, but we will plunge in here. We're glad to be doing this presentation. Lynn, if you want to go to the next slide. This is actually, I'm hoping that all of you that are listening are aware of the landscape review that Lynn and I undertook. Lynn, I guess it was now over a year ago that this process began. So what we're going to do is actually I'm going to be giving you a bit of an overview of what the mandate of the review was, how we actually undertook it, what we're calling our approach, and then at a very high level, some of the summary findings to give you a broad picture and context. And then there are many topics. So Lynn will then move into specific key recommendations by topic. We're not covering all of the recommendations. If you want to see all of them, they're actually in the report, which is available both on the ministry site and the MAP Center for Urban Health Solutions site. Okay, so next slide. And so now is about process. So this is our mandate. So landscape, so we were to describe the current features of occupational disease landscape from both a prevention and a healthcare point of view. And we were specifically asked to use a clinical lens in doing that, and to develop recommendations for a roadmap to improve health outcomes. So we wanted to be really clear up front. So while we're looking at both the healthcare system and the prevention system. Excluded from our review, it was difficult to exclude these things, but all were excluded were WSIB claims processes and compensation, the actual funding and resourcing of the health and safety system, MSKs, and mental health. So that was the context. And then these are the topics we were given for the review. I won't read them out. I'm hoping you can see them as we go through. Well, actually, I'll tell you the first 5 are very much about more of the health and safety prevention landscape, although it begins to blur around disease. Well, actually begins to blur around medical screening and disease surveillance and cluster management. And then when you get into 6 and on, it's actually about capacity within the healthcare system. Okay, so this was our approach. I'll just take a minute on this so you have a feel. We started with Lynn actually, and her team took the 9 topics and actually reviewed research findings that were related to them and recently commissioned papers and reports. So recent were what, Lynn, probably in the last 6, 7, 8 years. You didn't go back much further than that. And then at the same time, there were many information gathering interviews, again, around specific topics. And then those findings were synthesized by topic, and then we took that to focus groups. So we ended up with three wonderful groups of people who were focus groups for us. The groups met twice. So one group was health and safety system funded system partners. Another group represented more of the worker labor side of the equation. And then a third group was focused more on the workplace and employers. These groups stayed together over 2 focus group timings. So in the first focus group, I also wanted you to know that the actual organization of the focus groups and the analysis of the findings from the focus groups was handled independently by a survey research unit at the MAP Center for Urban Health Solutions. And those findings were then presented to us. They actually contacted all the people for the focus groups. I actually facilitated the focus groups. Lynn actually did not attend, so there would be no sense of speaking to her. I facilitated, and then survey research unit folks actually did the analysis. The first set of focus groups, we actually tested our findings by topic to validate, but also go further and deeper. And then the second set of focus groups, we actually had the survey research unit had done the analysis across all 3 groups by topic. And we presented that information back again to the 3 groups, and again asked them to validate. It also gave them a chance to hear at a higher level what we were hearing across all of the perspectives. At the same time, we began to do further consultation and interviews on what we were actually finding. And you're going to hear about those findings when Lynn starts to go through the specific topics. She'll give you a high-level sense of what our findings were. So we did consultation interviews and many presentations to, again, validate and test. And I'll give you a sense of what our criteria were for that. And then we did a final report. And part of our contract for this review was that we also do a visual synthesis. You'll see some of those visuals. We worked with an artist at OCAD who knew nothing about our field, who listened to us over the course of 5 or 6 months and then developed some visuals for us. So that's a bit long-winded, but we wanted you to have a feel. We really, really wanted to build on past work and also hear from different perspectives what the issues were, what the solutions were, and get a feel for what was feasible and practical. Okay, next slide. I'm into the summary now. So we just have a couple of slides here. Here's one of the visuals. So our underlying primary visual sense that came through all of this discussion and analysis, that from the perspective of the worker, the healthcare system and the health and safety system are two solitudes. So for the worker who's learning about exposures and the relationship to their health, they're really looking in one direction to their workplace and to their union and to their employer and to all of the many health and safety professionals in our province. They're looking there to get information, advice, support, be protected. Once they have symptoms, however, they're looking in a completely different direction for help with those symptoms, whether it's respiratory illness or skin issues, vibration, etc., hearing loss and cancer. So from the worker's point of view, the individual's point of view, these are two quite different worlds. And as we dove deeper, there is actually a pretty significant divide between the two systems that requires some significant bridging. So next slide. So here in more text form, again, there are pages and pages of findings, but our summary high level is that the current health and safety system approach to OC disease prevention and health recovery there is a lot of effort, but only incremental progress is being made. And we outline some of what people think may be the reason. So there is progress, there's a lot of work, but the impact is still incremental. The second is that the crucial link between exposures at work and symptoms of disease is very difficult to make, or may be difficult to make, and it is often missed. So even if there's an attempt to make the link, it's hard. But a lot of the time it's being missed altogether, and this impacts not just health recovery, but also prevention. And finally, that the two systems, I've already said this, are not well connected. That's the health and safety system in Ontario and the healthcare system. They're not well connected around this specific issue. This is again, another image. I wanted you to see that our goal was to move from this perspective of a worker having to look in two quite different directions and deal with different complex systems to a point where the worker is being, it's all integrated. And in this image, there's a lead on that gets you to this point, but in this image, the circle around the shoulders and the head of this person is intended to be an integrated health and safety system that's protecting, informing, empowering the worker around their health. And then the line at the bottom is intended to be the care pathway. So once there is an illness, that there is a clear set of protocols and paths to actually get the person hopefully well and back to work. I think there's one more slide. Yeah, so this was, we got a fair bit of advice in the focus groups and interviews, not just about solutions, but what we called guiding principles and system design features. So I'm going to go through this really quickly. And then if you could bear this in mind when Linn moves into the recommendations, these principles and design features actually informed how we actually move to develop recommendations. And in the report, you'll see there's short-term recommendations, longer-term recommendations, but also some guidance around implementation. So the guiding principles are around at each step going forward, the recommendations have an intent of building bridges between the two systems. And that's bridges at every level. A second really critical one that came out, well, all of these came out very strongly, is to inform and empower workers at each step in the prevention and healthcare journey. This is not a shift, it's an enhancement of a lot of the work that's been done around protecting workers to actually move to not just inform, but actually empower them with tools and resources to help them at each step. A third is to build trust in data at every level, collection, integration, and use. A lot of discussion about why are we collecting data, who's collecting it, what's it for, how do we ensure the integrity, etc. And trust came through as a theme of low trust around data. And the fourth guiding principle is to prioritize. This will not be a surprise to any of you listening, I'm sure, is to prioritize prevention services for smaller workplaces and industries with where workers are most at risk. So there is an equity principle that flows through the report. So design features, again, we got a lot of advice. We feel quite strongly about these as features to consider in implementation. We need to get clear on purpose first. This will become particularly clear in the workplace, the recommendations around medical surveillance and workplace, but also the surveillance system, clusters, etc. We need to get clear. Someone needs to make a decision on what's the primary purpose and then figure out what the design and solutions are. Clarify roles and strengthen accountabilities. We got a lot of feedback that there are a lot of different people doing a lot of different things all around similar topics, and we need to clarify those roles. Leverage, there's a lot of great expertise and activity, but let's leverage it and build versus having fragmented efforts. A lot of suggestion, and we put it fairly strongly in the report, to centralize wherever possible some of the core activities and then customize by sector or job or workplace as required, but start with central development and then finally to set performance standards and monitor. So that's a very quick snapshot of the findings, and it's our findings, but it's actually, I hope people will hear it's your findings. This was our synthesis of what we heard from all the very many people who participated. So Lynn, I think that was my final slide. Yes. Yeah. So now Lynn will move into each of the topics and give you a view from that perspective.
Thanks, Janet. So what I'm going to do is, excuse me, go through each of the topics. I'm going to talk a little bit about our findings from our focus groups, our interviews and research and reports from the past. Then present what we think are potential goals for the system around these various topics, and then talk about some of the key recommendations. Just for ease of presentation, we have not put in every last piece of information about all of the recommendations. So this is really kind of a summary synthesis of the key parts of the recommendations. So the first topic is awareness, recognition, and reporting. And it's in a sense where we need to start. Do we even know there's a problem? If we do, are we recognizing it? And is it being reported somewhere? So our findings, which won't be a surprise to folks that are listening, is first of all, there continues to be a lack of awareness amongst most of the health and safety system parties and healthcare providers with respect to occupational disease. Exposures that can cause occupational disease, and then how do you make those links? So that lack of awareness leads to under-recognition and under-reporting, which again is no surprise to, I'm sure, most of you. And as Janet talked about earlier, there are a variety of implications if things aren't recognized and are not reported. So clearly, if they're not recognized, if that link between the exposure and the disease is not made, that will have implications potentially for treatment. But it also potentially has implications for surveillance, compensation, and prevention, because one of the things that we know is used to look at, what might be priorities for prevention activities, is also often looking at statistics of, how common are these particular injuries or diseases or illnesses. And so if they're not recognized and not reported, those numbers appear to be low, but in fact, they're really much higher. As far as specific reporting requirements, and in spite of the fact that, I think there's constant efforts to be clear about them, there continues to be confusion amongst both health and safety system and the healthcare system providers about reporting requirements. And we're thinking here about reporting requirements to the Ministry of Labor, Immigration, Training, and Skills Development. There is a requirement around reporting of occupational illness and also reporting to the Compensation Board. And the other challenge is that we have those two kind of main reporting systems, but there's not necessarily a standardized way of collecting that information, of sharing that information, which means that even looking at those two core reporting systems, we're not necessarily using them optimally. So our goals that we're suggesting are, first of all, we need to increase awareness of the link between exposures at work and disease. We need to improve recognition and reporting by all the workplace parties and by physician recognition of occupational disease. As I go through, I will tend to use the word physician, but one of the keys in this is that although the emphasis is initially on physicians, we do recognize there's potentially opportunities for some of the other healthcare disciplines. And so again, as I say, I will use the word physician, but it's potentially a broader set of clinical folks that could be involved in the longer term. So our key recommendations are first to launch a public occupational disease awareness campaign. And when we talk about this, we're really thinking about the key system partners, those organizations that are funded by the Ministry of Labor, and I'll just use Ministry of Labor as opposed to the long name from now on. And really working together. And an example we might use from ODAP previously, the group worked together around a noise campaign. So what we're suggesting is that the system really looked to developing a broad public awareness campaign. The other thing we've done throughout the recommendations, because clearly there are many, many exposures that can cause many diseases. So generally speaking, we're suggesting starting with the designated substances. They have been identified, and there's some legislative requirements around them for some of the other topics we're going to talk about. And we're suggesting that as a specific topic to start with, we start with silica. So what we might envision is in 2024-25, there really is a concerted effort across the system to increase awareness around silica, where you might find it, the potential health effects, and how you might prevent exposure. To help with that, we're also just suggesting the development of a suite of OD recognition tools. These may be things like posters, videos, but just a variety of other tools that would support an awareness campaign. We're also suggesting implementing self-screening tools, starting with, again, lung diseases and skin diseases. There are tools that exist. They're easy to use. And again, this would give workers some ability to actually self-screen themselves, and then if there are abnormalities, potentially follow up. We're suggesting a shared data strategy between the Ministry of Labor and the WSIB around their systems to start with. And equally within their systems, they're not necessarily optimized to get information out easily. So I think there could be substantial work in improving the systems to get helpful information out and to also share that information better. And finally, we're suggesting with all of these things that there could be some technological kind of enabling. So for instance, there might be QR codes in the workplace where you could kind of swipe the QR code and you would find information about the exposure key prevention strategies. So those are our recommendations for that topic. And I'm now going to move on to workplace training. So our key findings were, first of all, there is, generally speaking, a lack of occupational disease specific training. There are occasional training courses provided by a variety of the training organizations, but generally speaking, there are not a lot of them. There may be some occupational disease training built into other training, but there's not a lot. There is a concern about the effectiveness of WHMIS. This comes from a variety of sources. Often if there are training tools, they're fragmented, there's duplication of effort in developing them. And for a lot of the training, there's not a lot of standardization. Another feature, which is maybe a longer term goal, but again, there is often a lot of focus on training. The person had training, but not necessarily a focus on what did they learn from the training. Have they now new skills, understanding of exposure so they can change how they actually work. So moving from we've counted how many people took this course to actually what is the impact of the course on work. And equally, there hasn't been a lot of evaluation of the training programs and again, their actual impact. So the goals we're suggesting are employers and workers receive relevant, timely, and useful information about the hazards in their workplace, the associated health effects, and methods of prevention. And that this information is provided in a manner that it supports a successful acquisition and subsequent effective use in practice. So our stretch goal is that Ontario is a jurisdictional leader in health and safety, continual learning and training. And then what we've done is suggested a few building blocks. So a very practical building block is developing e-learning modules for key exposures that may cause occupational disease. And again, we're suggesting starting with the designated substances because there are requirements within those regulations for training. While e-learning modules may not be the most effective way of training, what we're suggesting is they're a way to start. They would be freely available. They would hopefully be co-developed by the system partners who could then customize them if necessary to particular sectors or jobs. And again, hopefully over time, as training becomes more robust, you might use one of those e-learning modules as part of a larger training program. But equally, particularly for small workplaces, this is a way that would provide those workplaces and their workers with at least some basic information about the exposures. Again, we're suggesting that it would be important to trial different ways to reach some marginalized workers and workplaces. Peers are used in a variety of settings, and so one example might be to train kind of peers who would then kind of take the training into the workplace as opposed to more traditional courses being offered by health and safety professionals or other trainers. To come back to the issue about making training really effective and impactful, changing the audit focus from compliance, i.e. kind of, 90 workers completed this training program, to really saying, can you demonstrate the knowledge and learning from that program? As I say, we've suggested starting with the designated substances, but then we'll move on to the other key hazards. And probably one of the bigger suggestions is that WHMIS be redesigned. I think there's clear views across the system that WHMIS could be much more effective. One could build into a WHMIS program a lot of basic information about occupational disease, exposure, routes of exposure, effects. And so redesigning WHMIS and equally making it workplace specific so that we know that individuals have actually had a chance to look at the data sheets in their workplace, go through them, understand them, and that happens with their team. So those are the key recommendations around training. So we're now going to move on to medical screening. So this is workplace medical screening. Where you would find this probably most specifically, again, goes back to the designated substances, which for a number of them, there are requirements for medical screening as part of the regulation. So the reality is, from a system perspective, there's very little clarity about what's happening with medical screening. There's really not a lot known about kind of if it's being used, what's happening with the results of the designated substance screening programs that are in place. We don't know very much about who's providing the screening, and there is certainly concerns around, again, as Janet mentioned, trust. And trust in this whole process, particularly from a worker perspective. And finally, the screening data is not connected in any way to a provincial surveillance system, which in the ideal world, if the type of information is appropriate, would be good. So the goal is to improve screening for designated substances and then potentially other exposures, to support early recognition, which leads then to timely follow-up and diagnosis. It would hopefully identify trends earlier, inform prevention, and also potentially cluster identification. So in this case, we're suggesting as a first step, we need to try to assess the current state of screening, and starting with the designated substances. So is it happening? Are workplaces offering screening programs? If they are, who's doing them? What's being done with the results? Another component of this is that information knowledge changes over time, and there is not currently a kind of formal review of the various requirements for the medical codes for the designated substances. So we're recommending that there is a clinical group basically put together that would on a regular basis review the requirements and make sure that they are informed by current science. Again, kind of once we understand what's happening, we have kind of current best practices, then try to really develop a programmatic approach to this, identifying potentially other exposures where it might be relevant, and simple self-screening tools for workers, which we talked a bit about in awareness. And I think the final piece of this is, you know, how might the results of this be linked to potential surveillance systems? And we have to remember that for medical screening, sometimes the screening itself doesn't lend to a diagnosis. But on other hand, things like when one has lead exposure, blood leads, that information could be potentially more easily merged with a provincial system if we had it. So those are the recommendations around medical screening. Moving on to disease surveillance, and I'm pointing out that the topic was disease surveillance, not exposure surveillance. As Janet mentioned earlier, there is, I would say, general agreement that we need a disease surveillance system, but I think that often people talk about it, but there's not necessarily real clarity about what the actual purpose for the system is, and therefore what the system should actually be. What are the, in a sense, are the methods for disease surveillance? There's no clear responsibility or accountability. As Janet noted, there are at times concerns about the quality of the data. and the concerns again about trust in the data and where the system would be housed. So the goals, we're suggesting real-time usable data to inform prevention and identifying emerging new risks or clusters, developing capacity to detect trends over time and help measure the impact of prevention efforts, and that the system, whatever it is well understood, specifically related to its purpose and mandate, and that the data sources that are used for the system are clear and that they are trusted sources of data. So our recommendations are that the first step is one has to clarify and be clear on what the purpose of the disease surveillance system is and from where it will operate. So to give kind of two potential examples, in one case, the purpose might be to identify current exposures in the workplace which are causing diseases today. An alternate system could be to look at diseases and try to identify if they've been associated with exposures in the past, not necessarily exposures today. Those are two quite different purposes and actually would potentially lead to different ways of designing a disease surveillance system. And so once the purpose is clear, so we understand why we're doing this, then ministry needs to bring together, we're suggesting, bring together experts, both of kind of the methodological experts, but also the various parties which would use the data to develop basically the plan to implement the disease surveillance system for Ontario. And a somewhat related topic is cluster management. So again, everybody knows about clusters, but tends to use the term somewhat differently. As with surveillance, there's really no clarity on who has, if you like, kind of the authority to identify a cluster. There's no agency responsible for investigating clusters. There's no formal protocol. And I think it's also important to note that clusters, historic clusters and current clusters, there can be a lot of concern and anxiety and a variety of emotions with workers, their families. And so communication is a really important component when we're thinking about clusters, and we need to recognize that it's a really it's an important issue that we need to understand. So our goals are to, again, try to get some clarity around the definition of potential different types of clusters, the purpose for investigating clusters, clarifying the roles, sorting out the process, standardizing data capture for tracking and surveillance, and again, improve transparency and communication with everybody concerned. So again, somewhat like surveillance, we feel there needs to be an agreement on how we're going to define clusters, the purpose of investigating clusters. And as a start, we've identified kind of two groupings of clusters. The first one, which would be for basically acute or long latency, potentially illnesses that are being caused by exposures in the workplace today. And often in this type of cluster, the clinical diagnosis is a really key part of the activity. So needing an ability to get the appropriate clinicians and specialists to investigate the cluster. But equally, one has to recognize, and again, particularly potentially in a small business setting, there also needs to be a response capability to help the workplace. So how is it going to improve those exposures, prevent those exposures from happening going forward? And then the other kind of grouping that we have kind of noted are for the long latency historic clusters, where it's often a historic exposure in the past. So the workplace may no longer exist, or it may be very different from what it was when the exposures occurred. And again, there needs to be kind of a clear development of a protocol as to how we identify those, how we investigate and manage them. And clearly there are a number of cluster investigations going on, so we need to figure out kind of how to manage those as we move to potentially a clearer process for this. And equally, again, we need to think about how the results of cluster investigations might be linked with the provincial surveillance system, again, to help inform prevention. So again, it's this issue about, we have a number of activities going on, all which might provide information which is important to surveillance systems, but how do we make sure that the information and all of that is getting linked together in one place? So I'm going to move on now to the healthcare system side. First of all, was the topic of basically health human resources and its organization. So our findings that the academic occupational medicine capacity in Ontario is limited and is increasingly fragmented. Given the current setting in primary care, some of our expectations of what the health and safety system may desire may not be realistic. Even when we have physicians who are specialists, they're not necessarily well linked or supported. And then, as I said earlier, although I tend to be talking about physicians, we clearly recognize there are other clinical providers like nurses, nurse practitioners, who could also potentially be involved in this and need to be better integrated into the system. So our goals are for improved clinical capacity, both at the specialty level, but also in primary care. We need to try to enable primary care to provide the appropriate care for those with occupational diseases, and then, as I say, address other health disciplines which maybe have a role in the system. So we're suggesting we need a provincial academic hub for basically the focus for occupational medicine in the province. This provides specialized clinical services, but also would be the site for training for occupational medicine and other specialties where kind of the occupational component is relevant, as well as kind of the academic research site. For some particular subspecialties, and again, I'll start with respirology, it would be really helpful to have a regional network of specialists. For most specialties, there are one or two or a few in the province that have a particular interest in occupational illnesses and diseases. But if we could get them more networked, it would be, I think, helpful both for diagnosis, but also potentially for surveillance and even cluster investigation. Primary care, as I say, just given its current state, I think we need to understand how we can actually figure out feasible ways to improve their involvement in the occupational health response in Ontario. They're so overwhelmed, and anytime I go to a rounds or listen to something, one of the answers always is, well, if we could just educate the primary care provider more, if they could just do more. So we really have to understand what their challenges are, what the barriers are, and then figure out ways to help them facilitate identification and care of workers with occupational disease. Navigators are used in some other kind of settings for other issues within the healthcare system, and it might be that a health and safety navigator embedded in family health teams might be of help. And as I've said before, the roles of other health professions. Healthcare journey. So one of the other challenges in the healthcare system is just the challenge of, again, having a clear path. So If a problem is potentially identified in primary care, who do I refer that person to? Where do they need to go? We don't necessarily have a lot of guidelines for occupational diseases. There is some, but there's not necessarily, it often resides more on the health and safety system side as opposed to the healthcare system side. And the other thing is there are some diagnostic tools. There are diagnostic tools that have been developed in Ontario, but they have not really been integrated into care. So our goals are early recognition of possible occupational disease leading to timely diagnosis and treatment to achieve the best possible outcomes for the worker. The use of best practice or evidence-based care throughout the worker's healthcare journey, and continued applied clinical research to improve the diagnosis and management of occupational disease. So to help enable that, we're suggesting developing clinical pathways for common occupational diseases. An example I might cite is Australia has done a lot of work around silicosis and have developed a pathway, but I think that would be helpful. And again, this is a pathway which doesn't necessarily start just with diagnosis, but would consider primary prevention. It would certainly consider whether screening was important, but equally, what do you do? Kind of how does that screening happen? How do you interpret the screening? Then moving into the actual diagnostic process, return to work, and further outcomes. As I say, we do have tools. We have some tools that have been developed in Ontario, but they've never really been implemented on a province-wide basis. So we're suggesting that we actually try to do that. There is a tool focused on occupational asthma, which has been developed and trialed in primary care sites and is currently being validated further. If we do implement clinical pathways, again, we're suggesting they need to be evaluated through a knowledge translation framework. And then, as I say, although we're recommending starting with designated substances and common occupational diseases, as we develop them, we can figure out what the next pathways need to be. And we'll move on to physician education. So our findings from our focus groups and interviews was occupational health knowledge and competencies vary depending on the level of training and specialty. While didactic medical education is evaluated, so you take a course in medical school and there is an examination, and so you can evaluate the student's knowledge. We actually know we have little evaluation in the actual practice setting. And the other thing that, although there are continuing education opportunities offered, generally speaking, the number of physicians that are availing themselves of those opportunities tends to be low. So our goals are that all physicians are aware that work is a determinant of health and is relevant, and as it's relevant to their scope of practice, that they have the knowledge, skills, and tools to appropriately diagnose, treat, and help prevent illnesses related to exposures in the workplace, and again, relative to their specialty. And they understand and can navigate the health and safety system as appropriate for their specialty. So they understand the basic roles of the Ministry of Labor. If they needed to get in touch with them, how do they do that? And equally understand the workers' compensation system. So our recommendations are expanding the Workplace Champions program. It's currently primarily focused on medical school education, although there is some work being done in primary care, but we're suggesting that it formally be expanded to include primary care training and to continue to look for ways to evaluate it using any information we get from a scoping review that's currently being done. Clearly, occupational medicine is relevant, but there are a number of specialties where occupational disease is also highly relevant. Respirology would be a good example, but there are additional specialties like dermatology, neurology, oncology. So really kind of identifying some of those key specialties, subspecialties, and trying to increase occupational related training in those disciplines to continue to try to advance continuing education opportunities. And then, as I have said several times, to expand this to other specialties and potentially other disciplines. And I think the final topic is occupational information in the electronic medical record. So the healthcare system is in transition with respect to implementing EMRs. The reality is there are a number of EMRs that are in use. They can be further basically modified within a practice. So the EMRs don't necessarily speak to each other. They certainly collect information in different ways. And primary care's EMRs may not be the same or linked with EMRs that would be used in, say, a hospital setting. We don't understand how a physician actually takes an occupational history or considers occupational exposures in diagnosis and treatment planning. And there are many barriers to taking and recording an occupational history, given the time constraints of practice. I'm sure everybody, as one listens to the news, there is a lot of concern about the administrative time that is being taken in primary care. So our goal is appropriate occupational information in the electronic medical record to facilitate the physician's practice, thinking about prevention, diagnosis, and management of work-related disorders. Clearly, our focus was on occupational disease, but these findings are applicable really across the various health problems that may result from workplace exposures. So our key recommendations: understand how the information is used in practice, who is best suited to collect the occupational information, and what information is needed as a baseline for clinical care. We're suggesting, again, using the asthma history tool to actually, in the respiratory network, to understand the barriers and facilitators to collecting that occupational information. We think, and starting again with lung cancer as a specific example, there are certainly in Cancer Care Ontario, there are pathways for the major types of cancer. So where in the lung cancer pathway could taking an occupational history and using that information appropriately be cited in that pathway? And then based on the results of those, move forward in that family health team incubator to try to implement and evaluate the collection of occupational information in the EMR. And that is the end. So I see Kimberly, so I'll turn it back to you and I will stop sharing, hopefully.
That's okay. You can keep sharing because the summary recommendations are up. But don't worry if you don't wish to. I just wanted to pop on to make sure we had time to catch you for questions. And I want to thank you both so very much. It's always nice to have, a big report summarized succinctly and with all the background information. And thanks for sharing that today. I did want to ask or comment in our journeys together, collaborating to reduce and control exposures. I know you had a lens that was forced, and I know you had items that were removed from your scope. But I did want to point out or ask the question, was anything around actually, I'll use firefighters as an example. I see your focus on awareness and training, and then on the medical side of things. And I think the Alcohol Illness Prevention Steering Committee together, we're going to actually reduce and control exposures so that people don't get sick. And I think that whole in between is missing a little bit. And I wondered if you wanted to speak to that. Was it out of scope? Was it, it's sprinkled, I suppose, but I hear awareness, training, reporting, and then I hear medical.
Yeah.
So I did want to just give you the opportunity to talk to that really important piece.
Yeah, so Kimberly, certainly it's important. Our scope was very specific. They were those specific topics. So you'll notice when I was talking about even surveillance, I was very clear to say disease surveillance. We recognize there's also exposure surveillance, but our focus was disease surveillance. So I think as one reads the report, the fact that there isn't commentary about reducing exposures and those things does in no way means it's not important or it doesn't need to be addressed. It was just not in our scope. So as I say, we had those so we kind of had those general exclusions, but we also had those very specific topics, and that's what we were to address. And I think part of it was because it was through a clinical lens, the kind of, how you reduce the exposures in the workplace is not primarily a clinical question. It would be more a hygiene question, I would say. So, so certainly kind of from a disciplinary perspective, one might say our report was not necessarily addressing, kind of a lot of the activities that hygienists might do. But as I say, it was very specific to those topics, and that's why those things weren't discussed, but it in no way should be meant to infer that they are not important. Clearly, they are absolutely important.
Great, great. And please feel free to raise hands, folks. Show yourselves, put your questions in the chat. Sarah is writing, getting to this stage to recommendations seemed like a Herculean effort. Thanks, Sarah, for making me say Herculean on a Friday afternoon. I hope I did that okay. Congratulations, you're pushing well beyond incremental change. Awesome. It's okay, Sarah. So yeah, big thanks to you for all these efforts. And if there are other questions, please, we only have our speakers for a few more minutes before they're off and running. There is a comment around 50% of injuries occurring among healthcare staff are due to musculoskeletal exposures, which was also out of scope. Yeah, so that's a really good point. But that it has been addressed by the speakers that it was, again, not within their scope. I did want to know how has the reception been for you folks? Like, are you, meaning like, are you seeing action items come out already? Are you invited to tables where we get to grab onto this and do something? As you know, we love that. So we love that piece. How have you noticed that that piece happening?
So I'm going to use maybe a very, very strange example, but
yeah.
I was chatting with somebody who is a property manager in a very small organization who said to me, "Oh, your report has generated all kinds of discussion within my kind of community of property manager folks. We're really grappling with it." And I was kind of stunned because, clearly kind of, partners in the system and that have comments, but I was really amazed kind of that this, frontline person, kind of property facilities managers were discussing the report. I just found that really intriguing, and in some respects, as gratifying as hopefully the system partners talking about it and what can we do. And, I would say, Kimberly, the other thing is hopefully, as the OI table continues to do its work, a number of these recommendations, particularly the ones that are focused on the health and safety system, hopefully the OI table could lead the way in looking at some of them. And again, the notion of picking, because as I say, there's so many exposures, we can get overwhelmed. But with the silica control tool, we've identified silica. So let's build around, let's kind of create the silica package, all of the pieces around silica, and then we can hopefully just kind of replicate it for other groups of exposures, specific exposures, whatever.
Excellent. Thanks for that. And Sarah's actually asking, because we've seen these reports before and we hope, we have hopes, right? And they, what happens is so she's asking, were you able to recommend timelines and priorities? I saw priorities, but I wondered if there were timelines discussed or as a result of your report.
So there aren't like specific X days. There are kind of, I would say, shorter term and longer term. So for instance, in training, you know, starting to build some of those building blocks can be like now. Redesigning WMIS, you know, and potentially kind of could WMIS be one of those, you know, kind of mandatory accredited kind of training programs. That's clearly going to take a bit of time. That's a bigger kind of piece. So what we tried to do was include some, I'm going to say, more concrete, shorter term activities that by and large would be building blocks to some of the larger kind of aspirational pieces.
Thank you. And I did put a link in the chat, and thanks for mentioning all the clinicians and of course the interdisciplinary teams that it takes to look at this. As you know, with OCal, with occupational health nurses, ergonomists, hygienists, and physicians all working together to make that link. So it's important that you mentioned the clinicians and in your work. And there was a question on how you envision the connection between occupational disease database with the project to have a provincial exposure database that is underway.
I think it's an excellent question. And again, it goes back to kind of, I think, you know, our point is we actually need to think like what you think through, okay, what is the purpose of this? How do we then do that? And how is it linked overall? So it's really, in a sense, saying to the system kind of, you know, again, kind of the exposure database that kind of has been announced is a building block, but we also need to think about how is that going to be used? Can it be linked to other things? It's really kind of thinking those things through and having an appropriate group of folks kind of who work through those questions, I would say.
Thanks. And it's interesting. One of our occupational health nurses, Cheryl Rook, sent a link to a rounds, PHO rounds event coming up November 23rd. And I threw it in the chat, but it seems to, of course, it's a larger perspective with the public health lens, but nice to see, you know, social determinants going to be discussed, and maybe it will dovetail into your report, and they are talking population level policies and programs, reducing the risk of incidents of chronic disease, but also with a focus in there amongst many with occupational and environmental exposures. So I just threw that in the chat for folks. Nice to see that, you know, things, whether or not they were related, already happening from the public health Ontario side. And I don't know if you want to speak to that at all, but I did want to throw it in the chat.
Yeah, so maybe I can, as a final comment, because I have to go off and teach our residents. So I think kind of from a primary care perspective, you know, work is one of the social determinants of health. Primary care clinicians who are working at these things, you know, are looking at how do they improve history taking around social determinants of health. So again, you know, to get engagement from primary care, it may be that saying it's not this specific isolated occupation thing, it's part of your social determinants of health package, like kind of when you're collecting that basic information for the patient. So I think, you know, that placing it as a social determinant of health really helps because there's a lot of work going on in primary care, particularly those kind of that have a broader equity kind of diversity base in trying to figure out how do they improve history taking around social determinants of health and then using that appropriately in their practice.
Thank you. Thank you so much. I know you have to go teach. Ina has a hand up, but I think you might be late. Ina, I don't know, Janet, if you want to take a chance at one more question. Lynn said that was her last, and so I appreciate. Do you want to give it a shot, or should we just take a stretch break? You call it, Janet.
I'll take a shot, but probably without Lynn. I have to be careful what I say.
Oh, no, Ina is, it was a mistake. So we get to all now take a,
Okay, great.
Thank you, Janet. And thank you both. And we are now going to take a little stretch break. We'll come back at 10 after and hear from Dr. Anil Adish, who's going to talk about the ECHO OEM providing tools for primary care to get work done. So